A TAVI round session, so everyone is allowed to ask comments and interrupt us anytime. Let me just quickly go to our second. So we're leaving the aortic valve landscape and we're going to the tricuspid. I think we feel much more educated after the last two sessions on the tricuspid valve. So we're going to show a case of a 78-year-old female, BMI 20, rather thin lady. So she has been complaining of shortness of breath, at rest, fatigue for the past few months and has been up-titrated to her medication. She has been recently hospitalized due to dyspnea and congestive heart failure symptoms. She's been suffering from rheumatic heart disease, so she has been having lots of previous procedures, surgical AVR 2010. She required a valve 13 years later in the aortic valve. Another pertinent history of atrial fibrillation, hypertension, and hypothyroidism. So these are TT images, as we always do in these cases, parasternal long axis. Not the best video right now. With good ejection fraction, let me just go a little bit further. Mild MR, so we can see the aortic valve is functioning well. A Vmax of 2.6 and a mean gradient of 15. Remember, this is a valve-in-valve aorta. Apical four-chamber view, we can appreciate the mild MR, maybe some mild to moderate mitral valve stenosis. Rather enlarged right atrium and right ventricle. And we can appreciate the sizes here as well. Enlarged right chambers. Dimensions measured. So we have been talking about who are the ideal candidates for tricuspid valve therapies. TAPS on the left side, TDI on the right side. Seems that we have a pretty good functioning right ventricle. I don't know if Dr. Chrissohris would like to comment on these images.
This is transthoracic images of the tricuspid valve, 3D images, and we can see very nicely that this is a valve that has a very big malcoaptation. The anatomic regurgitation orifice is huge, and as expected, she has torrential regurgitation. It could be an element of a little bit maybe rheumatic involvement of the leaflets, but she didn't have stenosis. It was torrential TR. You can see also the restricted septal leaflet here, very limited mobility, a big coaptation gap that would preclude the positioning of any edge-to-edge devices. And the coaptation gap was about 15. So again, this is transthoracic subcostal views. That shows torrential TR with an ERO of 0.7 square centimeters.
So as we are evaluating these patients, we're very fortunate to have very detailed measurements. And of course, we don't know beforehand what kind of procedure we're gonna, or what kind of device we're gonna choose, but so the companies do send back their reports. So considering that this patient, I don't know, maybe, Chairman, we would like, just before we decide which kind of therapy, repair or replacement, before I go into some details for the Evoque valve.
It depends what kind of arms do you have, right? So up to now we had only TIR, but now it seems there is a new armament. So it's the TTVR, right? So let's see, how did you plan your procedures? As you did a CT analysis, I suppose, yes?
So these are the CT measurements. We do measure at the tricuspid valve annulus and at 5 millimeters below. Ideally, we need to have some oversizing so we can avoid in the future that the valve might be dislodged, and that's why it's pertinent to know and note down the weight of the patient during the CT scan and during the actual procedure, because as we said, this might change the plan eventually in the future. And of course, we need to have measurements from the right atrium, the right ventricle. We need to know the distance from the IVC and the SVC to the income of the right atrium, because maybe some of the valves and the technology that we have might not be working if the room is very small. And of course, we have other detailed analysis of the valve-in-valve procedure that we can see. And of course, we always have, as we mentioned in the previous TV sessions, to have the invasive hemodynamics, both from the echo, but of course from the right heart catheter. So we have this 78-year-old patient, frail, very symptomatic, has all this rich surgical history, and these are her Euro score and tri-score, and a without significant coronary artery disease.
So it's a high risk for surgery. So I noticed that the indication that you have with Evoque, there is no mention for high risk score, right? It's not like the tier. So you can actually, it's an expanded indication, and you can correct me if I'm wrong. So it's when you have the FDA approval, it's in the tier. It says that you need to have good anatomy and high surgical score. But in Evoque, it doesn't say that you need to have high risk for surgery, right?
Well,
am I right, or am I right?
Dr. Reardon's.
Low risk for surgery, you need to fix that mitral valve at the same time, because that's not dramatic. That's a right heart that's failing because of the left heart problems, and that mitral valve is causing more trouble than you think. You may think the gradient's 9 and there's moderate, but just look at that heart. That heart's sitting behind a really bad mitral valve, and that's what's caused the whole right heart to start to fail on you. So anytime you get the right heart look like that, they're all high risk. But if there's a low-risk patient, you need to fix the mitral valve at the same time.
So you think, if I understand it, we should start from the, as we always do, from the left valve, right? So,
there's a lot of reasons, but if you just look at that, that's a right heart that's failing on the basis of left heart disease. You fix the aortic valve, that mitral valve is causing more trouble than you think. So if it was low risk, you wouldn't be doing an Evoque. You'd fix both valves if you really want to fix the patient, but it's clearly not a low-risk patient.
Okay. So, Michael, any comment on that?
Would you be concerned about the pulmonary pressure of 55? She has good RV function based on TAPSI and RV S prime, yeah. But do you think that will cause any issues with the right ventricle?
Well, your right ventricle has been slowly trained, so that's helpful, and certainly that wouldn't dissuade us from fixing her mitral valve. There's no really pulmonary pressure that's too high to fix mitral stenosis. But again, what's really going to add to the risk is the fact this patient has already got some pretty significant right heart symptoms. He's got some pulmonary artery hypertension, got a fairly big right heart, even though it's working pretty well. And that's going to add to any surgical risk that I do. And again, if I'm going to think about operating this patient, I'm not going to leave that mitral valve alone. That mitral valve is a bad valve. And now, fixing her torrential TR and see if that makes her better, that's fine. But you're going to, if she lives long enough, you're going to have to deal with that mitral valve sooner or later. There's too much MR to do a balloon. Maybe there'll be a better valve-in-valve for us transeptal at some point. But yeah, all those things worry you. But I mean, the reason that you've gotten to where you are now is the mitral valve's bad.
So in an ideal world, you would fix the mitral valve first. But we don't have, the correct device for that. We don't have the Intrepid. We don't have the EOS. How would you fix the mitral valve first? Would you do that?
I think as of now, based on hemodynamics and so on, we've qualified it as moderate. One could do a MV area assessment by transesophageal echo and see what the number is actually. But definitely, you have to consider that this mitral valve is causing trouble here. But we don't have any good devices for the mitral except for a tendyne valve, which would be a transapical device, should the patient be a candidate. Overall, the heart team evaluation was that the mitral valve at this point could be on hold.
If I can make a comment here. This patient, initially, it was thought that the aortic valve degeneration, the bioprosthetic degeneration, was the problem of the patient. And despite the very low velocities there, it was 2.5, 2.6, it was decided in another center that TAVI should be done, and that would resolve the problems. At that time, the mean gradient of the mitral valve was measured to 4 or 5 millimeters of mercury, and the tricuspid regurgitation was like oversighted, despite that it was torrential since then with this huge gap. So not strange that TAVI didn't make any change in the symptoms of this lady. She came back requiring something more. And now when we see the other two valves, we see moderate mitral stenosis, I agree, but it is stable. And what we see on echo is a huge torrential tricuspid regurgitation with this very large gap. So I think it's the order we approach this multivalvular disease, and I think at this stage the larger problem is the tricuspid valve. And then for the mitral valve, I think we can certainly do balloon valvuloplasty for palliation, because there isn't the mitral regurgitation is very, very little, very mild. And why not one of the TMVRs that hopefully are coming soon, like the M3?
Good. So in hindsight, the heart team in the 1 year before, maybe it should investigate the possibility of reduced surgical multivalvular approach, more thoroughly, Mihaly.
To be a high risk for, but I agree with you. In hindsight, at the point of possible redo, but it would be a redo aortic valve replacement. Yeah. So it would be a very difficult.
Very difficult, and one has to do what one has to do, right? So maybe we cannot do everything. So how did you proceed?
So big discussion, obviously. This is the landscape. All these images have played before and previously regarding all possibilities. We do know now, after all these sessions, how the Evoque valve actually is. There's 2 interchangeable stents and 9 anchors that go actually below the hinge points of the tricuspid valve leaflets, and there's a 28 French outer diameter sheath delivery. So we have the white knob. We have a white knob. We have, for the ventricular release of the valve, we have the blue knob for the atrial release of the valve, and we have the primary flex and the secondary flex knob, and we have the third knob, which is for the depth of the valve as we implant it. So our initial step is always proglides, dilation of the right femoral vein. We use 8-point French. This is an Agilis steerable guide catheter, and you can see the stiff wire placed very gently into the right ventricle. We'll make sure that there is that it's not caught anywhere in the papillary muscles or anything that could potentially cause trouble later in the procedure.
And this is a Safari small, right?
Sure.
Extra small? Extra small, yes.
And of course, this is a very, you need to be very patient with this procedure. It's fully dependent on the TE and the images that we get. And
here we have reconstructions from mid-esophageal view. The imaging is not great, actually. And I think most of the procedure, we actually did it with transgastric 3D imaging and multiplanary reconstructions from a transgastric position, if I remember well. But the quality of the images is not as good as we would like it to be for at this stage. It's acceptable, but not perfect. And so we see now we've moved into this transgastric view in order to reconstruct from a 3-dimensional image all of the necessary planes that we need to. And with that, we're actually able to do it very well.
And this is how we slowly release the anchors based on what we see on the TE images. It's a very slow process. We need to make sure that we are below the tricuspid valve annulus, but we're not very well deep into the right ventricle, into the apex of the right ventricle, because then we'll have difficulty into actually being able to pull back the valve. very slowly releasing again, as you can see, until we reach 90 degrees. This is what we call the flipping of the anchors. And now we're very starting to release the ventricular side of the valve. And we can see the images from the TE that is actually driving us.
At this point, yeah, we've also, before we looked at all the anchors to make sure that the leaflets are sitting above the anchors and we're not pinning any leaflets outside. So it's a very deliberate process to make sure we see all the anchors.
And we always get to see here where we are. After we've finished with the ventricular release, we're going to the atrial release, and you can barely see here, the valve is almost ready to be released. And of course, we always keep an eye on what the TE shows us. And you can see now the valve is fully released. And we always make sure to see whether the valve might have candid, might have dislodged. And we take many angles. I don't know, Dr. Spargias, if you would like to make any comments?
No, Katsianos, everything is fine.
And another angle to make sure that everything is working fine.
Yeah, and this is obviously 3D after the procedure, looking from the right atrium, the valve. If I recall well, there was a small PVL, nothing exciting, but a small PVL was present, which actually diminished in the follow-up transthoracic images the next few days.
And this is a TT image.
And this is transthoracic images while in the hospital. The stable position of the valve, nice laminar flow through the valve, and a small paravalvular leak next to the septal area.
So it's almost a complete elimination of the TR. So what's the follow-up? Did she improve the symptoms of the patient? You know?
So basically, these are the first initial cases we've done in Greece and in Europe, to that matter, after it has been commercialized.
Yes.
And all the patients seem to fare good. Improvement of symptoms. Obviously, we don't have long-term outcomes, more than 2 months right now, but phone follow-up that we have, they're happy. So if they're happy, then we're happy. We're waiting, now we're collecting all these patients to our database and our registry and to make sure that we can have some kind of follow-up.
Okay.
But there seems to be a positive effect, but it's too soon to say anything right now.
Clinically wise, they are better. Of course, echocardiographic, did you have an echocardiography in these patients?
Of course, we had also discharge echo. We didn't have any issues pertaining to right ventricular dysfunction on clinical grounds. We didn't have any issues, and she went home, actually, if I recall well, at 4 days of follow-up for hospital stay. So stable medical management. We didn't have any.
I can add that she's doing well and certainly improved after this procedure compared to the improvements she had after the TAVI procedure.
So she needs less diuretics, I suppose? Yeah.
So we don't tend. Oops.
Yeah, his symptoms are improved considerably. So I would say that she's now happy with her daily activities and can do things that she couldn't do before. She's coming for the 1 month follow-up, I think, the next few days. So it's too early, but the first messages we get from all these first patients are very encouraging.
Okay, so anyway, Evoque is approved for better quality of life, right? Not for there are no hard endpoints as far as I know. So this is the FDA approval, right? Michale?
I think the TRISCEND was a comparison between the TRISCEND study. The pivotal TRISCEND study is a comparison between Evoque versus medical therapy, correct?
Correct. Yeah, but there are no hard endpoints, so it's only quality of life.
Sure.
So we should stay there, I think, for the time being. And another question that I have, many of these patients, they have pacing-wise, how do they fare when you place an Evoque? It's like
So
the Edwards, the other sapient valves that we place in a ring?
So the pacing wire, as we heard before, it's good that it has some slack, so you don't get to damage it. Of course, you need to have a backup plan in case everything goes wrong. We've done 3 cases with pacing wire. We didn't have time to show them. We didn't have any problem. They had some slack, so we need to work with the EP colleagues here as well. Now, you said what will happen if the valve eventually would degenerate? I couldn't hear you, sorry.
Yeah, but the pacing wires. So what's happened with the pacemaker?
So we didn't have any issues.
No.
So we know from the studies there have been some side effects, some conduction abnormalities. We did have one, but it just went off by itself within a few seconds. So otherwise, no, we didn't have any problems with patients with pacing wires.
Okay. So do you foresee any changes, major changes in your practice? So when you deal with severe or torrential TR, that it's in the yellow zone or red zone for TriClip or Pascal, you would go ahead and place the Evoque, I suppose, right?
Yeah, I think if anatomically they're not suitable for edge-to-edge repair, then that's the only thing you have as an alternative. But if they are suitable for edge-to-edge repair, then you really have to convince yourself that with edge-to-edge repair, you're going to have a durable and good result. Because nowadays, when we do edge-to-edge repair in the tricuspid, we really think very carefully about our results, and we're very mindful that if we don't get a good result and we do implant a Pascal device or and we have a moderate residual, then the patient does not have any other options.
Okay. Good. Good. So if there are no other comments from the audience, so. Okay. Exactly. So we have an accurate device in the same patient, also an Edwards, Evoque, and maybe next year in DREP into the mitral. So yeah. Okay, good. Thank you.